I'm going to go through 6 key challenges and potential responses informed by work we've been doing in the context of clinical trials, hybrid designs that are type 1 and type 3 over the past few years in different settings, both clinical settings and HIV settings in the hospital, emergency departments, as well as in the community. So challenge number 1, and this I think harkens back to some of the things that Denise raised around really trying to make sure you hit your sample size. So reaching your target population, that's a really important challenge, right, that we all face in the work we're doing. And thinking about the socio-ecological model, right, this is our favorite framework to think about. You know, you're going to be, depending on the type of study you're doing and your research question, you're going to be focusing on different people or in different contexts right here. So just to focus first on the individual, how are you going to reach your individual patients or clients that you want to reach? So first, I think you want to understand the barriers to recruitment. There's quite a bit of literature out there about what, was that a hand raise? No, that was a stretch. Awesome. So first, you want to make sure people know about the study that it's happening, right? They're not going to know unless you help them know about it, right? Some of this is really obvious. You want to think very carefully about your eligibility criteria. Do you want to have internal validity? Do you want to have generalizability? What do you need to balance there? You want to think about, you know, what are the barriers as it relates to stigma and mistrust? We heard a little bit about how that showed up yesterday in the context of the study around tuberculosis. What are the research complexities? What are patient preferences? And what are social and structural barriers? This reference here provides some nice examples just to solidify this as you're thinking about the designs of your trials. This was based on a qualitative paper looking at barriers to enrollment of patients with opioid use disorder to engage in a trial with injectable naltrexone. And they surveyed, and it was 26 people from 6 sites, the research staff and the providers. And they just highlighted some of these things. So some of the eligibility criteria that got in the way is maybe they were too restrictive because they were looking to enroll only individuals who had a unsuppressed viral load. So that left a lot of people who couldn't participate who may have benefited. Opioids was not the primary drug, and so they got kicked out of the study, even though, again, they may have benefited. You know, contact information. We have often and experiences in the past, we've really wanted to help optimize retention. And so we've required a certain number of contacts that the patient is able to give us before we're going to include them in the study. But actually then that limits generalizability, especially if you're doing research at the intersection of HIV and substance use, right, where people may not have a strong social network and people that they trust that they can give you that information. So you really need to think about that. Fears of others learning about their status of their disease condition, HIV status, substance use, right, that gets in the way. Internalized stigma as well. Lengthy procedures and fear of the research process, right? So often people don't want to stick around if they're coming in for treatment for their, opioid withdrawal symptoms, right? And they're acute, like newly engaging in treatment. They're not going to necessarily stick around for a 3-hour intake process, right? And you may have, if you're working in a site where they're not familiar with research, they also may not understand why you have to ask all those questions, right? And so really talking through with the individual you're trying to engage and the context so that everyone understands, like, why do you have that lengthy battery and why is the research process what it is? Research complexities and patient preferences. So thinking about the treatment preference. And so patients may not want to be randomized. They may not be open to receiving a different condition. So in that context, you can talk through what are the pros and cons of the treatments and how is their clinical equipoise, right? And I think also, as an aside, making sure your research team understands that too, because sometimes your research team may have different biases that are going to impact that engagement process, right? We are coming up against that in a study where we're looking at injectable buprenorphine versus treatment as usual, and some of the research team members have some biases around, but if I give an injection and it lasts for a month, patients must do better. But we don't know. That's why we're studying it, right? And then social and structural barriers, so housing and transportation, criminal justice involvement, and thinking about how that's getting in the way. And so just to offset some of these things, right, by these different domains, multi-pronged recruitment approaches is really important and can be very useful. Limiting exclusion criteria to maximize the generalizability, especially when we're in the implementation space, right, and effectiveness space. Train your staff to maximize the patient comfort, engage stakeholder input in recruitment materials, so things are going to be accessible to the population you're trying to reach, right? And warm handoffs. So if you have, if you're recruiting in a clinical setting, can you engage the providers to introduce you as or your research team to the client so that it's not uncomfortable, it's less uncomfortable for them. Streamline your procedures, provide the rationale, provide education. I said this already. And then you can provide transportation for study visits and offer referrals for services. So if they're coming in and have a housing issue, is there something that, even if it's not related to the study, can you provide some services to them so that it's really meaningful for people, right? Beyond just the research itself. Does this make sense? I know some of it is obvious, but I think it's, I find it to be a helpful reminder that when you're planning your studies and doing it, to really be deliberate about it upfront and as you're thinking about things. So just to talk a little bit more about optimizing your recruitment up front. So again, patient-facing materials is key. And again, you want to create materials that are going to feel accessible to individuals that you're trying to reach, right? So they see people that look like them, right? And it's relatable. Create clinician-facing recruitment materials and engagement strategies, right? So I always say to our research team, like, if I'm going in to see a patient and a great research team tells me right before I walk in the door, I have this great study, can I see your patient when you're done? By the time I'm in and out of the room, I've completely forgotten. And it's not that I don't care about research. It's not that I don't want to make that referral, but I've just forgotten, right? Because I'm engaged with whatever is going on with that patient. And so just to make sure that the research teams are making it as easy as possible for the clinical team and making, again, breaking down all those barriers. And then direct research-driven efforts. So if there's direct outreach from the research team and to the patients, reaching out in advance, and sometimes, depending on your institutional review boards and processes, sometimes you can do direct outreach, sometimes you can mail letters, and if people don't opt out of the study, then you can do a cold call, but you have to work with your local ethics board. This is just some examples from our study of how we've tried to do this. This is from our smoking study that I shared with those of you who were here yesterday. So this is a trifold. Just imagine it folds up, and this is just, oh, maybe that's blurry for you. I'm sorry. Is it blurry? Oh. Just to have some information for a patient who's interested so they can take a look at it and make a decision later, and they have the contact information. And then this, what's the health record system like here? Do you guys have electronic medical records in the hospitals and clinics? No. Okay, that's helpful to know. So this was something we were able to do in our health record that maybe is not relevant here at this time, but maybe in the future, so that a provider, this is a snapshot of a best practice alert that we've created for providers. Yeah. I understand. Okay, thank you for clarifying. So you do have electronic medical records. Perfect. Thank you. I thought so. Okay, thank you. That's helpful. Okay, and then here, monitor progress with how you're doing with recruitment. So define your targets up front, understand the underlying denominator, right? And that's sometimes really hard, especially if there isn't systematic screening in the sites where you're working to recruit patients. You may not know what the underlying denominator is and the underlying disease prevalence, right? But to the extent that you can get at that, that can be really helpful. And then you want to monitor and then refine strategies. So this is an example from this figure. We just had this paper accepted yesterday. And it was based on our, thanks. Yeah, we're excited. Thank you. This is a study where we're recruiting in the hospital to evaluate different strategies to address alcohol use disorder. And we are focusing specifically on recruiting a racially and ethnically diverse patient population. And so what we had done is, you can see here in the blue is hospitalized patients with alcohol use disorder. This is an imperfect denominator because we are recruiting those who are not in treatment for the alcohol use disorder, but we weren't able to readily capture that with the health record. And so this is, this is again, an imperfect denominator, but this is looking at patients hospitalized with alcohol use disorder. We looked at who was eligible but not randomized, who was not eligible, who got randomized, and then 34-day follow-up completion. And we were pleased to see that we've been able to do better at recruiting Latino populations into our study, and we're hoping to improve our sampling of Black patients. And so this has helped inform our procedures. So just an example of how you can kind of build it into your systems, and we're a year plus into our recruitment, and so we're going to try to iterate that a little bit further. So thinking next with implementation science studies, you're often going to be thinking about different levels of the system, right? And so clinicians and staff are often a target for interventions, and recruitment. And so a couple of suggestions around that, and we've been doing that for some mixed method studies and also intervention work. So first, you want to get leadership buy-in in that setting, right? That's key, right? I think it's really, really key. If you don't have leadership buy-in and you're trying to engage nurses and providers in that site, it's going to be really hard. It's going to be really hard without leadership buy-in, but that is going to be key, right? And hopefully you're, probably essential to getting in the door. I think it's helpful to be, as a next step, is create an opportunity to introduce the study and its goals, right? What are the aims? What are you trying to do here, right? To the clinicians and staff. If there's like a standing routine pre-clinic conference, that's what we call it, where people are coming together anyway, can you, get on the agenda there, so you're not adding a meeting for folks, but you have an opportunity for some FaceTime, and then have a follow-up invitation. So, if you're preparing a survey, can the clinic leader send that invitation out to the staff? This is a really important problem that we're trying to solve. We really want your input. Here's the link for that survey that we want you to complete by the study team. And you can draft that survey. You can draft that email for that clinic leader to make it really easy. And then, we beg, right? So there's follow-up, right? Personal engagement, and bring food, right? And again, try to elicit their perspectives that way. And we've been successful with a number of evaluations that include mixed methods. Let's see. Personally, I was going to say we beg. Okay. And then lastly, I want to think more broadly. So thinking about the context where you're trying to do the work, I think that's really key. This has come up in one of our trials where we're in the community for a PrEP study, where we had to think about site alignment and realignment. So we were all mission driven. I think it's really important to be mission driven, right? Like you're trying to solve a really important problem. We are trying to get individuals with opioid use disorder on PrEP and evaluate a treatment strategy to do that. You want to make your expectations really clear and revisit that and provide monitoring and feedback. So we had a site where we thought everything was going to be terrific. They had PrEP on site, they had harm reduction on site, they had primary care on site. We thought it was going to be perfect. And we could not, for whatever reason, we weren't able to recruit there. There just wasn't the numbers and there wasn't the foot traffic. And we had to break up with them as a site. And, there was promise of subcontracts and funding, and we had a great breakup, but it was really hard, right? You have to sometimes decide that there isn't that alignment the way you thought. And that's okay. And then other times you can, and I was really excited we were able to partner with Dr. Madden and act as a new site when we were pivoting and thinking about new opportunities. And so just to emphasize what Denise had said earlier is to think about what you're, how are you maximizing your resources to reach your mission, right? And then any questions about that? Is that helpful? Yeah, Irma. Oh, no. Okay. Does that make sense? Helpful reminders, I hope. Okay. So retention. So Denise made comments about this. So missing data is especially problematic, and especially if missing data is especially problematic if not missing at random, but it's really hard, right? It threatens the validity, reliability, and the usability of the results. And it makes Denise really unhappy when we have it. So we try to protect against that. And I found this nice, well, this review that I was hoping would be more helpful. This is in Cochrane, looking at strategies to improve retention in randomized trials. And, they pulled together a number of studies. This was published in 2021, so a few years old now. But most of the strategies that they had looked at, says, insufficient evidence for this, insufficient evidence for this. So we don't have a great source of data and evidence base to determine how to best optimize our retention efforts. And so I encourage you all to think about that and build that into the work you're doing, right? Because it's so important, right? We don't care, like it's not, I don't care, but recruitment's really important, but retention is really important, right? You have to equally think about those and I think a lot of times we get bogged down in our recruitment numbers, but forget about the importance of retention. And so there were some examples of things that seem to maybe have a little signal based on the read of the literature that I listed here. But the conclusion was, as it stands, there's nothing in the evidence base with high certainty evidence that can be applied to trials to improve retention. So big on, unanswered area for research for folks here to tackle. That said, we've been really lucky to work with Brianna Castanagwe, who's the first author of this paper, who is a retention consultant. She has just started her PhD program and works with our team on a bi-weekly basis to help improve retention efforts. This is a really nice paper for those of you who are working on this that I encourage you to read, but collect and track detailed locator information, right? That's really important. Update it at every contact that you have. Get social media, get emails, get updated contacts. Develop strong relationships between the research staff and the participants, and work with your staff to do that, right? Of course, you want to maintain professional boundaries, but you want your patients, your study participants to feel the love, right? That you care about them and in a genuine, meaningful way. Minimize barriers to participation. Be persistent, creative, and flexible in your retention efforts. So you can think about retention bonuses if you're having problems getting people in. Pay contacts for helping them connect you to the participant you're trying to reach. You can have study branded materials, backpacks, magnets, snacks, pens. Try to contact try contacts at different times of day and by different methods. So we always say, if you can't reach somebody during the day, try in the evening hours, try from a different phone number. And so we have our research staff rotate who's calling, and try at the end of the month and the beginning of the month, or different times. You can mail personalized letters, right? So I think about, I don't know what it is for you guys, but I think about my dentist, right? And that's channeling Brianna. It's like my dentist, whenever we have an appointment, it's like 3 phone calls, 3 texts, 3 emails to make sure we don't miss that appointment, right? And all these like real, postcards when it's my birthday, right? And my dentist doesn't care about my birthday, right? But they're trying to make me feel the love to come back, right? Many people don't like going to the dentist. And so think about what your dentist does to keep you to come back. And confirm, right? Really, confirm they're brilliant. What's that? Your does nothing. Oh, it's interesting. You can come to mine. Confirm and share phone numbers at study enrollment. So we say to our study team, like, okay, you have your study phone number, call the participant's phone at that moment, tell them to plug in your study phone, so that way you both, and save it, so that way you both have confirmed that phone number works, and then they have your contact. You can keep the team can keep a retention journal. So they're thinking about, okay, where might this person be and when, who's close to them. And again, to help maintain that contact. And then God bless you, hold standing retention team meetings. So this work is really hard and can be tedious. And it's really important to celebrate the successes and then also brainstorm together around it, around a specific case. And so our team does that on a bi-weekly basis in a really detailed way, and it's really helped. So challenge, any questions about that? Anything new that folks have learned from those strategies? No. Something? Anything? No. Everyone's tired. Okay. I'll keep going. Challenge number 3 is staffing, I think is really important to think about. And so depending on the type of study and where you are, that may mean something different. So, research coordinators, we've worked with social workers and case managers, physicians, clinical pharmacists, drug counselors, harm reduction and outreach workers. So I'm using the term broadly, right? Depending on what context you're working in. And we've worked with different folks on this slide here as the interventionists. So thinking about what the needs are for everybody. One thing I think is really important to remember for your research coordinators is just because they have been doing research for a long time, if you're putting them into a new context, don't assume, or new area, right? If they have never worked in substance use or HIV, don't assume that that they don't need more training, right? They do. They likely do. Just don't make those assumptions. We had a very experienced research coordinator now working in the hospital setting, and we've learned the opportunities for training and bolstering her comfort in that setting. And so just a reminder for you all. Interventionists, so we've worked with sites where we are partnering with sites, and the sites are helping us deliver the intervention in a community partnered approach. And it's really up to the sites to determine who's going to be that interventionist, not our study team, right? And so there's opportunities there to make sure that those interventionists, right, who are working on the study, understand, are excited about, buy into what you're trying to do. And so that, again, is really, really important. And if you can be engaged in that process and that choice, that may help you along the way. And then life happens, people get sick, vacation, there's job transitions. So, think about that and anticipate that as you're creating your study teams up front, right? How can you protect against knowing that these things happen? So just some suggestions based on our experiences to prevent and prepare for staffing challenges. Develop detailed manuals of operations and update that as you go. Here is just a screenshot for our manual for our hospital-based intervention. So we've detailed like a cookbook, what we want folks to be doing. We train them up on it. We do role plays, have a checklist for onboarding new staff. Record the training sessions if you anticipate there may be turnover, right? So that you don't have to retrain everybody in the same way, but they can dive into the training materials you've created, and then you can make sure that they are trained up. Participate in staff selection as possible and assess buy-in when you're working with partners, and then build and back up with cross-training. I just pictured here, we were so lucky that we had the same research coordinator for the whole duration of our smoking study in New Haven. She's going to be retiring and stuck around to finish follow-ups before she retires. So it was just amazing. And she was responsible for recruiting every single one of our patients in New Haven. All right, and challenge number 4, interventionists do not always follow the protocol, right? And we don't always have access to the things we want. And we've talked a lot about fidelity monitoring, but I want to get a little bit, give you some suggestions for what that might look like for when you're doing this work. So facilitate protocol adherence and build in fidelity monitoring and learning collaboratives. I think you can do that as you go, right? And as you prepare procedures. So here is a templated note that our clinical pharmacist created that we use to document in the health record what happened in the study visit. And so the clinical pharmacist, who's the source of the intervention, created based on the contingency management and medication strategies that we were evaluating. So it was like a checklist so that they remembered what the different pieces were that they were supposed to hit in that counseling session. And so it helped protocolize it. And it was acceptable to them because it was created by a clinical pharmacist, not what I thought made sense. And so this way, then we were able to use the data that gets documented in the health record as part of the visit, extract that into our data management system, which we use REDCap, and then we can analyze those data to check for fidelity. We've also been recording those sessions, and those sessions get listened to by an expert and he rates them, and he uses a, standardized measure. This is a, I guess David Gustafson wouldn't like this. It's a 7-point Likert scale. But to see if they're, how they're doing and hitting the different components of the intervention. And this has been really important. So, just looking at average scale scores, this is just 3 slides to give you examples of this based on the ratings that our consultant had done. Across average scores, they were quite high, and the pharmacists across the 3 sites were doing quite well. But then we looked at some differences, for one item looking at discuss self-report of tobacco use, they were generally doing really well. That was pretty good. But then there was a little more variability looking at assessing the patient's desire for rewards, which was part of the contingency management intervention. So that gave us data to provide feedback to the pharmacists. And then also these are things we'll be able to look at and see, how does hitting on these different metrics impact outcomes. And then it helps us now as we're thinking about next steps. What do we know we need to continue to work on, right? And bolster that. Where do we need to make sure we're doing ongoing training as we're thinking about scale up? So number 4, so just in terms of response based on those experiences, so build in structure to facilitate protocol adherence and with input, or even better, created by the interventionist from the beginning. Address any potential biases up front. Of course, invite questions, right? If people aren't asking questions, I always say that worries me, right? Regular calls with site interventionists and the coordinating center team to review fidelity monitoring findings and give feedback, discuss shared experiences and provide opportunities for co-learning, and discuss insights into challenges with intervention delivery. So that we heard about issues with access to one of the medications. One minute? Oh, okay. Oh, that went fast. Okay. And then you can turn gaps that you learn about into advocacy. So we had learned that there was problems with advocacy, access to the nicotine replacement therapy. We were able to use that information to document it and then advocate for changes at the state level for access to this very cheap medication. Okay, I'm gonna go quick. So hurricanes and COVID happened. So again, stay mission driven, be realistic, use the infrastructure to gain insights. So if you already have your research infrastructure, maybe there's a new, we did a mixed method study in that context when we got locked down because of COVID. Revisit the ability to meet recruitment targets and what the impact is going to be on your study goals, modify your protocols as needed and track that, and publish your protocol papers. I would say do that always, right? Because there's always going to be challenges, like publish those right away while it's fresh. You know what you've done, get it out, and then you update it and modify it as you need to. Report transparently and systematically capture this in clinicaltrials.gov and these online databases. You can use the framework that Mona referred to earlier. Engage your stakeholders, your funders, and team members, and revisit where you are based on unexpected challenges. And then get external input. We use a data safety monitoring board. It's been really helpful. Okay, I just want to say one last thing is, this is my last slide, if that's okay, is to communicate and share resources and community mistrust. You want to anticipate, this is really important, I think, and deserves a minute, if that's okay. Okay. You want to make sure you're doing everything you can to make sure you're optimizing trust with the community. So create opportunities for mutual learning, share resources, including funding, right? If you're working with community partners, give them money too to do the work. Don't expect them to do it, right? They are on thin budgets. Be present and communicate, show up, right? These are basic things, respectful things, but also invite them to participate in your dissemination activities, and make sure you go back and present your findings to them, to the participants, the patients, the staff. Make sure you're closing that loop, because I think that ends up hurting trust and engagement for future work, and is just really important. That's how you have impact, is the people that you care about who've participated get to hear what you've learned. So I just wanted to make sure I said that. Okay, I'll stop there. Thank you.